On behalf of Jagsonpal Pharmaceuticals Limited, I welcome you all to this webinar on infertility, filling the lacunae with theme learning, the continuous process. This webinar is an initiative of Lalita Memorial Hospital, Rewari, in association with Rewari Obs Gyn Society, supported by Haryana chapter of Indian Fertility Society, with the academic partner Naari division of Jagsonpal Pharma Ltd, makers of EndoReg, Divagest range, and newly launched LycoRed-M tablets. So we are proud to announce the launch of a quality product, LycoRed-M tablets for male infertility, a rational combination of N-acetylcysteine, L-carnitine, CoQ10, lycopene, zinc, and selenium. With added advantage to win the race, L-carnitine is sourced from Switzerland and lycopene is sourced from Israel. A warm and hearty welcome to all the esteemed faculty and attendees. Please post your queries by text in the Q&A box. And to refer to this webinar in future, the recording will be available at our YouTube channel, Jagsonpal Medical Insights. We now invite Dr. Seema Mittal, Director, Lalita Memorial Hospital and Infertility Center, Rewari, past President, Rewari Obs Gyn Society, and Treasurer, Haryana chapter of Indian Fertility Society, to kindly initiate the program. Ma'am.
Thank you, Deepika ji. Dear friends, welcome to our fourth episode of Filling in the Lacunae. Learning is continuous process. And we are really thankful to great teachers like Dr. Bela, Bhatt, Sunil, Takiar sir, and Dr. Sarpreet, who will be joining shortly, who have spared their valuable time and the busiest schedule. Thank you, Dr. Bela, traveling all the way from Goa and then coming to us. So without wasting time, I will just introduce my chairpersons for today's session. They are all masters in their field. We have Brigadier Dr. Sunil Takiar. He's professor at Falah School of Medical Sciences, Faridabad, and he has received Chief of Army Staff Commendation Award and GOC in Northern Command Commerce. Then we have Dr. Mona Agarwal. She is a consultant OBGYN and infertility specialist. She has advanced ART training from National Institute of Reproductive Medicine, Kolkata, and she has her own IVF center, and she's doing IVF, FOGSI, and her main field of interest remains infertility and fetal medicine. Then we have Dr. Santosh Yadav. She is consultant OBGY at KD Hospital, Mahendragarh, Haryana, and she has done fellowship in endoscopic gynae surgery and fetal medicine. So I now request our chairperson, Dr. Sunil Takiar, to invite the Master Blaster, the most demanded speaker for the evening, Dr. Bela Bhatt. Over to you, sir, to introduce our most charming, versatile Dr. Bela. Thank you, Dr. Bela, for being with us.
Thank you.
I think you have already said enough about Dr. Bela Bhatt in those very, very few words which speak volumes about her. The Obs and Gynae fetal medicine consultant from Mumbai, whom I have had the pleasure of listening over the past 2 sessions. And it will be I'm just waiting for the day when we can meet again. I hope she is coming to the March episode. An eminent person and really good. I won't come between you people and her deliberation. So may I now request Dr. Bela Bhatt to please carry on with the deliberation and enlighten us.
Yeah. So thank you so much, Rewari Obs Gyn Society, dear friend Dr. Seema Mittal and Sunil sir, for those kind words of introduction. As I already told, it's like an extended family now. So good to connect every month with our Rewari family and you all, dear friends and seniors. So, well, Dr. Seema Mittal is very, very particular in selecting a topic. And so this time, she has suggested this topic, third trimester scan. Now, this is very, very aptly chosen topic because we all have been talking about the first trimester scan, that is nuchal scan, the second trimester anomaly scan, right? About which a lot has been said, but third trimester scan, not much is talked about, but is equally important. We are going to see through this talk today that there are three important arms of third trimester scan. Previously, we always thought that third trimester scan is just looking at the well-being and the growth and and that's it. But no, we'll go through the presentation to try and find out as to what all we can, information that we can get from the third trimester scan. So as I said, the three arms, one is of course the biometry and the growth, in which we look not just at the biometry, but look at the interval growth charts, diagnosis of late onset fetal growth restriction, which I'll go into little detail, and of course, diagnosing large for gestational age as well. There are certain late onset or evolving anomalies that also we look at in the third trimester scan, or we do follow-up of previously detected anomalies. And third very important arm is about placental location, especially when there has been placenta previa has been diagnosed in the second trimester, and to rule out placenta accreta spectrum. Now, let's start with the biometry. So we all know the method of biometry, getting BPD, HC, AC, FL remains same as in the second trimester. So either you can do it to the transventricular plane or transthalamic plane, in which we will look at the biparietal diameter and occipitofrontal diameter to get our head circumference. So this is extremely important to get a proper HC. And then we go to the abdominal circumference. Now, in abdominal circumference, we all know the section is the same axial section where we should be getting the stomach and the portal sinus, but not the umbilical vein. Only one rib should be seen. And again, APAD, TAD, or ellipse, whichever method you are comfortable with, you have to take the abdominal circumference. In femur, we take the femoral diaphyseal length, that is FN. So all four things together will give us our expected fetal weight or the fetal size. Now, here there are two again important aspects when we are looking at the growth. One is when the proper dating has been done in the first trimester. What we try and look in the third trimester is whether the baby is growing on the same centiles. Now remember, of late, we all have been talking about the language of centiles. We don't compare the weeks of gestation on LMP and on ultrasound. No, that is not the way. We look at the centiles on which the fetus is growing. So we look at the graph in the growth charts, whether the baby is growing on the same centile, and that's a good sign that the growth is okay. Now, this is when we have a proper dating done, which is there in majority of cases, I think, nowadays. But there are few patients who directly come. I'm sure you also must be encountering, coming directly at 6 to 7 months. They don't have a proper first trimester scan done, no dating done. They're not sure of LMP. Now, how do you date this pregnancy? Because you'll have to fix a EDD for this patient. And based on this fetal size, you'll have to monitor the growth in the third trimester. So how do you date such patients? So what we do in such cases is we look at these parameters, BPD, HC, AC, FL, and what we'll get as the result is the fetal size. So how we write in the report is the gestational age can't be ascertained as the patient is not sure of dates and no early pregnancy scans are done, but the fetal size as per today's scan is so-and-so, and a rescan after 2 weeks is advisable to confirm gestational age. So we call the patient after 2 weeks and we look at the growth chart. If the baby is growing on the same centile, then we think that this is the best possible way to date this pregnancy, and we calculate the EDD and give the patient the EDD. This is about when you do not have the proper dating. So this we have discussed. Now, do we have any other pointers apart from the BPD, HC, FL, which will tell you whether the dating which has been done is proper or not? Yes, we have some helping parameters like the long bone ossification centers. Now, patient coming at around 30, 32 weeks, 33 weeks, 34 weeks, no scans done. Roughly, if you want to find out whether the baby is at the same centile or at the same weeks of gestation, then this is how we can come to know. So the distal femur, when we look at the femur, the distal femur at epiphysis will be ossified by 32 to 33 weeks. The proximal tibial epiphysis, as you can see here, is ossified by 34 to 35 weeks, and the humerus, the proximal humeral epiphysis will be ossified by 37 completed weeks. So we have three landmarks here. The ossification centers of the bones, which will again roughly tell, these are all to get the rough idea whether the baby is at the same weeks of gestation, because we do not have anything else, no other scans in the previous pregnancy. Now, as I said, these days 80% patients at least have some early pregnancy dating scans, and when such is the situation, then we look at the centiles and growth charts to find whether the baby is growing on the same centiles or growing well or not. So this is how we look at the HC, AC, FL and weight. And we look at whether when the scan was done before and now, whether the baby is growing well or the centiles are falling down, right? So when the growth remains between 10th and 90th centile, we are still okay. But what happens when the growth is falling? We all know in fetal growth restriction, there are two types, early onset and late onset fetal growth restriction. And what is late onset fetal growth restriction? When beyond 32 weeks of pregnancy, in absence of any congenital anomalies, the AC or EFW is less than third centile. Here, this Delphi consensus diagnosis, which is internationally used to diagnose late FGR, also uses the language of centiles. So how do you come to know the centiles if you have not put them, not calculated the centiles, or you do not have the growth charts? So ACFW less than third centile itself can tell you that if this is late onset fetal growth restriction, or if the AC and EFW is less than 10 centile, then either is or ACFW crossing more than 2 quartiles. 1 quartile is 25 centiles. So if the growth has fallen by 50 centiles, that's also a late onset fetal growth restriction. Or when the cerebroplacental ratio is less than 5th centile, or umbilical artery PI more than 95th centile. So any two of the three is present, then we label it as late onset fetal growth restriction. So obviously when it develops after 32 weeks, the diagnosis is in third trimester only. So third trimester, we have to be extra careful to look at the growth centiles and the trend. Now, here you can see in this particular patient, look at this. The growth centile at 20 weeks was around 53rd centile, but at 32 to 33 weeks, it has fallen to 5th centile. So there has been fall by 2 quartiles, 50th centile. So this is a late onset fetal growth restriction, right? Now, why is it important to find out the late onset fetal growth restriction? Because as against early onset fetal growth restriction, though this is just a mild placental disease, it is important to diagnose because fetuses at term more than 32 weeks have reduced tolerance to hypoxemia. There is relatively high metabolic rate, and they develop acidosis faster as compared to preterm fetuses. So chances of stillbirth is also high. Previously, there were many fetuses in third trimester, sudden stillbirth. We don't know the cause. Now we are able to find out, and we are able to monitor such fetuses and prevent stillbirth. I'm just going to give you an example of this through a case. Now, this is an actual case which happened in last 3 months, wherein there was 34 weeks, the patient was referred to me. She was a primary gravida with conception after 14 years of infertility. Now, this patient was referred to me at 32 weeks, 5 days. When I did, and I looked at the dating scan, which was there, third month scan, which was available there. So dating was proper. Now at 32 weeks, 5 days, the centiles of growth, the composite fetal growth was at third centile. The Dopplers were normal, but because it was at third centile, my concern was the growth is not proper. It is late onset fetal growth restriction. So my advice was to keep a kip count and repeat Doppler after 1 week. Because whenever there is first stage fetal growth restriction, we have to do weekly Doppler as per the Barcelona staging, right? So this was my advice. Unfortunately, next week, the patient, I couldn't go to that center for the ultrasound, and the patient was referred to a radiologist who did a scan at 34 weeks. Now, in his conclusion, what was mentioned was weeks on ultrasound corresponds with weeks of gestation as per LMP. There is no brain sparing effect and there is no fetal growth restriction. Now, 3 days after this scan, patient came with reduced fetal movement to that obstetrician, and they did section and there was a stillbirth baby of 1.6 kg. Now, such a sad incidence this is. The patient has followed up throughout the pregnancy, had infertility, had conceived. So now what is our idea is not a blame game, but we should do a good audit as to what went wrong, right? Despite diagnosing a late onset fetal growth restriction, what has gone wrong? And could we have prevented this stillbirth? Let's look back just to try and learn and not repeat the mistakes. So again, this patient's scan was done at 28 weeks by a radiologist who reported the growth as normal. But when I looked at the centiles, this was the centile. The centile at 28 weeks was 3.3. You can see here, composite centile. The AC was at 5.3 centile. So everything was on normal lower side. So when the centiles are, AC and EFW are less than 10 centile, it is a duty to look at the Dopplers. But the Dopplers were not done at 28 weeks, right? Here it was just mentioned that the growth is okay. So first thing is, you always have to look at the centiles, and when they are less than 10 centile, please order for Doppler, even if the radiologist doesn't do. Request him to do Dopplers, because otherwise you'll miss the diagnosis of late onset fetal growth restriction. After that, patient comes to me at 32 weeks, 5 days. As I diagnosed it as stage 1 fetal growth restriction, the umbilical artery flow was something like this. The diastolic flow was still good. The MCA Doppler was something like this, where the MCA PI was high. So the cerebroplacental ratio was normal. Umbilical artery and MCA PI flows were normal. But the growth was at third centile at 32 weeks, 5 days, which made me worry. So I had advice for kick count and repeat Doppler after 1 week. Now, at 34 weeks, now, when the patient goes to the same radiologist who did a scan at 28 weeks, the scan at 34 weeks, look at the umbilical artery. From the visualization also, we can make out that the PI has increased. Look at the MCA, the diastolic flow is increased. What does this suggest? This suggests brain sparing. But in the report, the radiologist had mentioned weeks on ultrasound corresponds with weeks of gestation, no brain sparing effect. But actually, when we compare the 32 weeks, 5 days scan and the 34 weeks scan, can you see the difference? This is umbilical on left side and this is MCA on right side. So 32 weeks, when I did the scan, the umbilical artery PI was normal, and it had increased from within almost 10 days from normal PI to such a high PI. You can see here the PI has increased in the umbilical artery. Not only that, what is extremely important in late onset fetal growth restriction is the cerebroplacental ratio, and therefore the MCA. Now, MCA PI, as you can see, at 32 weeks, 5 days was normal. Normally, the MCA PI is high. But look at this diastolic flow. It has increased at 34 weeks from 1.85. The MCA PI had fallen to 0.74 because there was increase in the diastolic flow. What does this suggest? There has been vasodilatation in the brain. What does it suggest? There has been brain sparing effect. Why is there brain sparing effect? Because there is hypoxia. The baby is badly trying to compensate. And when I looked at the cerebroplacental ratio, it was at less than 1 centile at 34 weeks. Right? From normal CPR to less than 1 centile. Suggest your brain. Remember, whenever the CPR is less than 1 centile, less than 5th centile, in fact, beyond 32 weeks, it raises a red flag. It tells you have to monitor very closely, because these are the segment of patients where sudden IUFD is very, very common. So what could have been done? We know there has been red flag. The MCA PI has fallen. MCA PI has fallen significantly. The MCA diastolic flow has increased. The baby is screaming at us that I'm hypoxic, I'm trying to compensate. This is a late onset fertile growth restriction. Monitor me closely. So either patient should have been admitted and daily CTG should have been done, or it was already 34 weeks. Give steroid and deliver the baby. Right? You know that sudden change has occurred in within 7 to 10 days in the cerebral vasculature, in the CPR, in the MCAPI. The baby is bad. The CPR is extremely important in late onset fetal growth restriction. This was missed, and therefore, by the time the patient came with reduced fetal movement, there was already fetal death, intrauterine fetal death. So 100% this could have been prevented had we been more vigilant in monitoring, looking at the Doppler reports. It's a responsibility of obstetrician also to look at the Doppler reports, compare it. The trend is extremely important. Look at the trend. What was the MCAPI last time? What is it now? What was the umbilical artery PI last time and what is it now? If you see that there has been changes in that, the trend is towards the CPR falling, vasodilatation, that shows in late onset fetal growth restriction that there can be sudden IUFD. You have to monitor them closely by admitting them and doing CTG, or 34 weeks plus, we have good NICUs, you can steroid and deliver for sure. 70% fetal growth. Remember, out of early and late onset fetal growth restriction, early are more severe, but out of all the FGR, 70% are late onset fetal growth restriction, and they are responsible for 40% of such stillbirths. So if you want to prevent it, we have to wake up and we have to monitor these patients closely. So what we can do, a good growth with Doppler at 32 weeks and 36 weeks, and look at the report, discuss it with the sonologist, discuss it with a fetal medicine consultant, and where the need is, you have to monitor it closely to avoid this 40% of stillbirths. So these small changes in our practice will have big impact as far as our perinatal outcome is concerned. So that was about fetal growth restriction. Not only that, we look at the growth chart. The growth ideally has to be between 10th and 90th centile. What on the opposite side of the spectrum? When the birth weight crosses more than 90th centile, or the abdominal circumference is more than 95th centile between 29 to 33 weeks, this is again raising a red flag. Why? What are we worried about here? About the sugars, of course. We are worried whether it is a gestational diabetes mellitus which has developed late, or we have missed picking up in the mid-trimester. So whenever in between 28 to 30 weeks scan, you find that the AC is more than 75th centile, the EFW is more than 90 centile, or there is polyhydramnios, idiopathic without any cause, it's a red signal. Please look at the sugars. Even if you have done it in the past, it was normal. Repeat 75 gram PG2BS test and try and find out whether the patient is having gestational diabetes mellitus, because again, we know if you miss this, there are chances of sudden stillbirths because of missed GDMs, which will, again, because of sugars, there will be hypoxia and acidosis, and it can kill the baby. So both the aspects, small for gestation age and large for gestation age, both are important in third trimester. That was about one arm, that is the growth. Well, we know we look at the anomalies on nuchal scan. We look at the anomalies at the 18 to 22 week scan. But remember, there are anomalies, 5 to 10% of anomalies, which are evolving anomalies, or they may be there in the beginning, but they may manifest in the late second or third trimesters. And therefore, it's our duty. The third trimester scans are not just growth scans. We have to screen the fetus from top to bottom to look at any of the evolving anomalies. And which are the common evolving anomalies? CNS anomalies, typically the microcephaly, some of the ventriculomegalies, intracranial cysts, the corpus absent corpus callosum, intracranial hemorrhage, and many such anomalies of CNS typically develop late in the pregnancy, late second trimester or third trimester. So maybe your second trimester anomaly scan was absolutely normal, but still there can be, and I'll give you some of the examples of this. Not only this, torch infection. Usually the periventricular calcification, ventriculomegaly, microcephaly, everything develops in the late second or third trimester. So again, look at all these markers, fetal ovarian cyst, cardiac rhabdomyoma, and there are many, many such examples, but I'll just discuss 2 or 3 cases of late onset fetal growth, the anomalies. Now, this patient was referred to me at 33 weeks, 5 days, primigravida, non-consanguineous marriage with mild ventriculomegaly. That was what there on the report of the radiologist. Anomaly scan, which was done at 18 weeks, was normal because obviously the ventricular size was normal at that time. So the radiologist was proper to diagnose no abnormality at 18 weeks. But at 30, these are evolving anomalies. So when the patient was sent to me, this was the picture of the axial scan. So again, whenever we do third trimester scan, we look at some of the important structures in the brain. Of course, we look at the both ventricles, whether there is ventriculomegaly, look at the cerebellum, but we also look at the CSP, cavum septum pellucidum, and this is a normal patient in which a CSP, it's a box which has to cut the falx cerebrum, and this has to be seen in third trimester. Now look at this patient which was referred to me. Can you see any such CSP? No, it is conspicuously absent. Not only that, we see a typical teardrop ventricles, and these two are the signs of absent corpus callosum. This is ACC, which is an evolving anomaly. There was ventriculomegaly, as you can see here, teardrop, and absent CSP. These are typical signs of absent corpus callosum. This was the sagittal section. Now, typically the baby had kept the hand over face, so I couldn't see the nose and the sagittal section. I tried to look at the pericallosal artery, which was absent here because it was absent corpus callosum. But as the baby removed the hand, as you can see, it's a mid-facial flattening with a proboscis-like lesion, which is there seen on the nose. And this was the 3D rendering, 3D ultrasound of this baby, which shows abnormality of the face along with the CNS anomaly, which is very, very common. So this was a case of ACC, which was diagnosed at 33 weeks, 5 days. And it happens because these are late evolving CNS anomalies. Now we know the chances of just diagnosing and counseling the patient, and see, now it is 33 weeks, 5 days, where the patient goes to the court and gets permission and terminates now, or continues till 36, 37 weeks. What is important is to try and find out whether there is any genetic cause, because we know in CNS anomalies, the genetic cause is very, very common. So what is important is either antenatal, take amniotic fluid, at least do a DNA storage, or when the baby delivers, take fetal tissue and do DNA storage, because the reason is not just to try and find out, but to prognosticate next pregnancy. And patient may not be ready at this point in time, but maybe after 3 months, 6 months, they'll be ready. The genetic lab will do genetic tests to try and find out whether there is any association, because that will help in planning next pregnancy. So that's importance of picking up anomalies even in the third trimester. This was a case where patient presented to me at 29 weeks, 5 days. Again, anomalies done at 19 weeks was normal, but this anomaly evolved later on. So this was very, very almost 7 years old case, before 7 years. So at 29 weeks, 5 days, what I could see was gross bilateral hydronephrosis, as you can see in the sagittal and the axial section. And there was a typical keyhole bladder, that is because of proximal urethral dilatation with bladder dilatation. So this was a case of lower urinary tract obstruction, or LUTO. Now we know there is a very high chance that there is the urethral obstruction which is leading to all these things. Now here I could also see a posterior urethral valve, which is the most common cause of lower urinary tract obstruction. This is the shadowing caused by the pelvic bone, but we can very well see the valve here. Okay, so we knew for sure that this is posterior urethral valve, which is causing bilateral hydronephrosis, hydroneurator with keyhole bladder. So patient was counseled that this is an anomaly which is treatable. Patient was referred to a pediatric urologist, neurosurgeon, in fact, antenatally, to try and understand the postnatal outcome. And patient was advised for karyotype, but they refused at this juncture. Pediatric monitoring was done weekly for growth, hydronephrosis, and LycoRed. Now, what is important in such cases is looking at the LycoRed, because as the severity of luto increases, that posterior valve obstruction, the LycoRed will reduce. So till the LycoRed amount is good, we can continue with the pregnancy, because as such, more are the weeks, less premature is the baby, better will be the outcome. So I monitor the baby weekly, and at 33 weeks, 5 days, there was reduced fetal movement. On ultrasound, there was oligohydramnios, and AFI had reduced from previously 11 centimeters to 2 centimeters. Steroids were given, and at 34 weeks, LSCS was done in a setup with inbuilt NICU with the pediatric urologist present there, and 1.7 kg baby delivered and handed over to the pediatric surgeon, who catheterized the baby with difficulty and later on operated for the posterior. The fulguration of the valve was done, and later on the surgery was done, and baby is doing very well. Baby is 7 years old now. So this is a treatable anomaly, but the importance is to picking. It was picked up at 29 weeks, followed up well, delivered on time at a center where everything required was there, and therefore the outcome was good. So to decide also where the planning of delivery and deciding where the treatment is required, which consultant is required, everything is possible if antenatally the evolving anomaly has been picked up. This was a case which was referred at 26 weeks. Again, 18 weeks anomaly scan was normal, but at 26 weeks, you can very clearly see the double bubble sign. The other bubble is by because of the duodenal atresia. So this was a case of duodenal atresia, wherein you can very clearly see the double bubble. And we know that this could be associated with some of the chromosomal anomaly, most commonly trisomy 21. So this patient was advised for amniocentesis. Amniocentesis was done, and this did turn out to be a trisomy 21 patient. And of course, patient went to the court, got the permission, and nowadays there is a medical board also available at so many places through which patient can terminate in the at the government hospitals. Now, as I said, the benefit of picking up late anomalies is few of them can be treated, like the lower unit tract obstruction. Then there are shunts like pleural effusion in vesico-amniotic shunt, or in hydrocephalus, or in meningomyelocele, which can be offered. Antenatal consultation and keeping necessary specialists at the time of delivery is something which is extremely, extremely important to improve the parental outcome. Planning of remaining pregnancy, place of pregnancy, cardiac cases which are duct dependent, it has to be terminated at delivered at tertiary care center, and prostaglandin has to be given. So there's so many things. Esophageal atresia, diaphragmatic hernia will need immediate treatment by the surgeons. So they have to be delivered at the tertiary center. And overall, the parents are mentally and financially better prepared to deal with the postnatal management, and therefore it potentially improves the overall parental outcome. So let's be vigilant. Late second and third trimester scans are not just growth scans. We have to look at the evolving anomalies as also. So these are two arms. The third, again, a very, very important arm is placental location, especially we have diagnosed in the 18 to 20 week scan or the second trimester, late second trimester scan, that there is placenta previa. There, it's very, very important in third trimester again to have a look at the distance between the lower edge of placenta and the internal os, or if it is already a placenta previa, whether there are any signs of placenta accreta spectrum. So there's quickly I'll tell you some of the signs which will tell us that there are high chances of placenta accreta spectrum, which can be placenta accreta, increta, or percreta, right? So in 70% cases, there will be loss of clear zone. I'll show you the images also. Myometrial thinning would be there, and placental lacuna. So what is extremely important is to look at this. Here you can see there is no hypoechoic zone between the placenta and the uterine wall. Here you can see, so this is densely adherent placenta. This is one of the commonest signs that you will find loss of clear zone behind the placenta and between the uterine wall. And second, very conspicuous sign is these large placental lacuna. You can't miss them. If you are doing a scan in a low placenta previa, you can't miss such large lacuna. And when you put on the color, Doppler in such patient, what you will find is utrovesical hypervascularity, turbulent lacunar blood flow, some bridging vessels, some feeding vessels. This is how it is going to look when you put on the Dopplers. So this is something which you will never miss. And once you know that these signs are there, you all know, I'm sure everyone of you have encountered such cases of placenta accutus, adherent placenta, morbidly adherent placenta. They need extra precaution because they have to be delivered at a tertiary center where blood bank is available, a team of surgeon is available, a multidisciplinary care is team is available, because the maternal mortality, the perinatal mortality, morbidity, everything is very, very high. Not only that, in many, many cases, you may need obstetric hysterectomy and whatnot. So, you know, I'm not going to go into details of all that management, but at least we know when we look at all these things, we know for sure that this patient has to deliver at a tertiary center, and therefore we can definitely improve the outcome of this patient. So through all the 3 arms in the 3rd trimester, what we are trying to do ultimately is to have a healthy mother with a healthy baby, a happy baby. And that's what all of us, whether we are obstetrician, fetal medicine consultant, whether we are IVF consultants, everyone want this final outcome to be good. So let's be equally vigilant in the 3rd trimester as we are in the 1st and 2nd trimester, and look at all 3 arms of 3rd trimester scanning and improve the perinatal overall outcome of the pregnancy. And that's the reason I keep telling that every obstetrician should be a sono obstetrician, a sono gynecologist, because that's how we are going to help each and every patient of ours. Thank you so much for patient hearing. Thank you.
So, Sunil sir is yes.
Yeah, I am here. I am here. It's always a pleasure listening to Bela. Thank you so much. First, it was our 1st trimester, now the 2nd, and now the 3rd. It's great hearing you. And we are all enlightened. Thank you so much.
So, Dr. Bela is incredible, but I feel this is grossly incomplete. So, next lecture, we're going to have details of the fluid, the placenta, the passenger, everything, because I think next session you will give us 1 hour.
It's a never-ending and always an evolving topic.
It's such, I mean, she's such a good orator. I get feedback from all my audience that this is the best presentation of all. So thank you so much. And next time, please keep 1 hour for us. So we now request Dr. Mona Agarwal to invite our next speaker, who is the king of embryology. And once you know him and listen to him, it will be real pleasure. So over to Dr. Mona.
I'm really thankful to Dr. Seema Mittal for making me a part of this academic session. And this is my privilege to introduce Dr. Sabarjeet Singh, who will talk on male infertility. And this is in fact a very important aspect of infertility, which should also be looked in every infertile patient. Dr. Sarabpreet Singh, he is MD from AIMS, and he is head clinical embryologist and andrology at Artemis Health Institute, Gurgaon, India's first ISHRAE certified senior clinical embryologist. He is convener SIG Quality in Art 2022 to 2024, and he is award for best convener, champion of ISAR award at ISAR conference 2020. The best SIG award at Fertivision, FIS Achievers Award, so many awards, Asia Pacific Medical Excellence Award, and he is a Vijay Ratan Gold Medal by Indian Solidarity Council in 2023. He is director at Fertility Academy, which provides online and hands-on teaching in reproductive medicine. Now I hand over the platform to Dr. Sarabpreet Singh for his valuable inputs.
So we can start with my lecture on endometriosis. Dr. Santosh is there?
Now we have the next session, which is endometriosis and assisted reproduction. I'm sure we all are having such patients in our everyday OPD because of its very high incidence, and especially when it is very difficult to treat when it is concerned with the fertility. Our next speaker is a renowned fertility specialist to guide us through this. Dr. Seema Mittal, ma'am, a renowned fertility specialist and gynecologist in Haryana. She is the director at Lalita Memorial Hospital and Infertility Center, Rewari. She was the first one to open the IVF center in Haryana, and serving the community for more than 20 years, which is a vast experience. She was past president of Rewari Obs Gyn Society and treasurer in IMA Rewari. Presently, she is treasurer in Haryana Infertility Society, Indian Fertility Society, and secretary of Doctors for Society. She has received many awards, including the President Award for her book Sukhad Matartav and sorry ma'am, I missed one more award. Yes, the award from Government of Haryana. Yes, she received the local champion award for serving the society from the Government of Haryana.
Thank you, Santosh. Thank you. So we all know it's a chronic inflammatory, very, very painful disorder, and it involves not only the uterus and its appendages, but other areas as well. And if we talk of infertile patients, 38% of the infertile women will have this. And according to Endometrial Society of India, 25 million, that is 35% of Indian women suffer from endometriosis. Diagnosis, as a clinician, we all know that it's based on symptoms first, and then we have all diagnostic modalities, that's ultrasound, MRI, and laparoscopy. Combination of laparoscopy and histological verification of endometrial glands is the mainstay in diagnosis. A negative diagnostic laparoscopy definitely rules out endometriosis. And as an infertility specialist, I feel without laparoscopy, I really cannot comment that this is endometriosis. Ultrasound definitely is diagnostic, but early cases especially are missed on ultrasound. This is a simplest classification which we follow in our clinical practice is that's minimal, mild, moderate, and severe endometriosis, where we find either the isolated lesions or there are lesions which are mild or there may be adhesions. There are lesions which are moderate, deep, or superficial with clear adhesions, and stage 4, where the lesions are multiple, severe, and they are both superficial and deep. And this is what takes us further to the diagnosis, management, and prognosis of all our patients in infertility. When we look at causes of infertility, endometriosis shares 25%. Friends, endometriosis is a clinical entity where we have been working for almost 100 years, despite enormous information and uncertainty is still there regarding its etiology. Advancement of innovative medical and surgical approaches such as gonadotropin releasing hormone agonist, both and antagonist, have changed the scenario for treatment. And laparoscopically guided laser ablation have proven very, very effective in improving the symptoms as well as the prognosis of endometriosis. Assisted reproduction is becoming an indispensable asset in providing couples affected with endometriosis with viable pregnancies. There are so many trials, so many studies going on, and we can say that endometriosis largely remains disease of infertile. There are patients, but when the laparoscopy was done, it was found that for infertile patient, you find endometriosis in 21 to 48% of patients. While when doing tubal ligation, it's only 1% where you find endometriosis. So mainly the endometriosis is diagnosed when patient is present to you with infertility or at times with severe dysmenorrhea. So what are the effects of endometriosis on infertility? In early cases, basically there are the hormonal disturbances, and in late endometriosis, it's basically the blocks, the distortion, and loss of anatomy. So they can be anovulation, corpus luteum insufficiency, hyperprolactinemia, and the most common, the luteinized unruptured follicle syndrome, which is so common and still I don't find an answer. And the spontaneous abortions are very common with endometriosis. Late onset can lead to loss of tube-ovarian relationship and adhesions. The various B cell activities and production of specific antibodies and T cell macrophage function dysfunction all are responsible for poorly affecting the implantation. There has been evidence that peritoneal fluid in patients suffering from endometriosis is another responsible factor, and various types of cytokines are responsible for inflammatory response in endometriosis. Another important point about endometriosis is that adenomyosis has been found in as much as 90% of the patients. So studies using MRI have shown that in patients with endometriosis, up to 90% prevalence rate of adenomyotic lesions in patients with established pelvic endometriosis. In early endometriosis, if diagnosed in time, these kind of complications can be prevented. So this is how the endometriosis and adenomyosis present. Use of medical treatments which are successful for non-reproductive symptoms have failed to demonstrate any reasonable improvement in fertility. Surgically ablating visible endometriotic lesions potentially benefits pregnancy outcome. So drug treatment does not help. In early cases of endometriosis, we don't need any treatment, but we have to focus on treatment of infertility as we treat unexplained infertility. Late cases of endometriosis will definitely require surgical intervention. So how do we manage endometriosis? Early cases, we go with controlled ovarian stimulation combining with intrauterine insemination. It has proven to be cost-effective, appropriate, and first-line management for treatment of infertility. For young women, but again, here's a clause. If the patient is young with only minimal or mild endometriosis, expectant treatment will be the most appropriate course. However, if she's in advanced age, the chances of conceiving with minimal treatment, they drop precipitously, and we have to go for ART methods like IVF or ICSI, which we'll be discussing subsequently. Use of GnRH antagonist in IUI cycle has also been studied, and there is no difference in patients with minimal or mild endometriosis when comparing to patients who have received placebo. It has not been found to be very, very effective. So this is a picture, just we are defining that mild endometriosis does not affect our endometrium, our tubes or ovaries, and if treated in time, we can prevent advancement of disease. And as we all know, pregnancy itself cures endometriosis to a certain extent. So diagnosed early, managed early really helps the patient. But for women with severe endometriosis or tubal disease, or when male factor or combination of any other etiologies involved, assisted reproduction such as IVF should be pursued sooner. So as a result, the increasing use of ART in the treatment of endometriosis associated infertility may help answer some of the questions. I always tell my patients that when we are doing IVF, there are certain diagnoses we can make only when we have taken up the patient for IVF, such as assessment of gamete quality, observation of fertilization, and evaluation of early development of embryo. And all these have been done at large in infertility patients. And as we will be seeing in subsequent slides, that it's basically the embryo, not the embryo, but the egg which might be at fault. Development of GnRH agonist and TVS has revolutionized the treatment, and results are really good. If I look back and see that maybe 20 years back, endometriosis, severe endometriosis, and that used to make me think that now patient may not conceive and she will not conceive. But now with revolutionized treatment of all our agonist protocols, even antagonist, we can get substantial number of good eggs, good embryos, and good results as far as fertility is concerned. So briefly, we will be talking about the effects of endometriosis on oocyte, endometrium, and embryo, and then we will be concluding. So endometriosis study suggests that oocyte yield was impaired in some studies. Some say that there was decreased folliculogenesis. Some say that there is decreased number of periovulatory follicle in patients with endometriosis. And a recent review suggests that endometriosis may have deleterious effect on folliculogenesis and oocyte quality, independent of stretching mass effect by the cyst. What we have seen in our experience that bilateral ovarian cyst, but still patients have very good reserve. only factor that is a little scary for us is patient's age. If you have a young patient who has got bilateral ovarian cyst, say it's 4 centimeter or 5 centimeter, but she will definitely give you good number of follicles, good embryos, and pregnancy as well. So improvement in IVF outcome is brought about by development of GnRH agonist, and it is largely undisputed. We will be discussing in our panel today because most of the centers are now going for anti protocols because that saves time and monetary also it's a little economical. But from our experience, we would say that agonist protocols, as long as patient is not a poor ovarian reserve patient, it gives very good results. The egg quality is good and the embryos are also grade A. Long-term GnRH agonist suppression has been thought to repress further endometriotic lesions and improve IVF outcome patients with endometriosis. Rickes et al. Reported significant higher clinical pregnancy rate after 6 or more GnRH agonist therapy compared with ovarian stimulation with gonadotropin alone. Another study also says that oocyl is better when compared to controls in patients who have received GnRH agonist downregulation protocol. Then there are further studies which say that agonist protocols are definitely better and better pregnancy rates, and we go with the studies, is our experience also. Patients treated with GnRH agonist, however, had significant higher number of additional embryos also available for cryopreservation and making the cumulative fecundity high. So, although the standard gonadotropin stimulation protocols work well, addition of longer agonist downregulation or use of continuous OC pills also, where cost is a concern, it will improve IVF success rates and should be considered on case-to-case basis depending on your patient's age, other associated factor, and male infertility factor as well. So, what about the embryo quality? With regard to early embryo development, researchers have reported fewer embryos with endometriosis, and there is reduced number of blastomere also at 72 hours and lower cleavage rate when endometriosis is compared with tubal factor or unexplained infertility. And further studies have shown statistically significant increase in incidence of aberrant nuclear and cytoplasm morphology within embryos from patients with endometriosis. Yes, we all know that endometriosis patients do give few eggs, few embryos, and there can be genetic defects also. But once we get healthy embryos, the pregnancy rate is at par with other patients. So endometriosis affects oocyte number, but not embryo quality or pregnancy outcome, irrespective of the presence of an ovarian endometrioma. And this we have witnessed in so many of our patients that in spite of big endometrioma, they have just uneventful pregnancy and pregnancy outcome. So now we will talk about endometrial receptivity. Endometriosis per se reduces fertility, we all know. There is a decreased pregnancy rate, we all know. But we have to pinpoint what is who is at fault? Is it egg, is it embryo, or is it the endometrium? So various studies have been done and they've shown that errors in implantation may be attributed to relation between endometriosis and adenomyosis. Endometrium per se in early cases of endometriosis is not affected at all and conception rate is similar. But in advanced cases, usually they have found that endometriosis and adenomyosis are together. And prolonged downregulation again helps here in improving the prognosis. So it has been suggested that endometriosis associated impairment of implantation results from compromise to the potential of oocyte or earlier embryo and not to the endometrium itself. So this study suggests that endometrial receptivity and subsequent implantation rate may not be affected by stage 3 or 4 of the endometriosis. Bela et al. Analyzed IVF cycles in endometriosis patients with stage 1 or 2 and stage 3 or 4 disease. They reported lower fertilization rates for patients with stage 3 or 4 endometriosis, but clinical pregnancy rates did not differ significantly between the two groups. Pregnancy rates are reported 70% over 2 cycles compared with 24% for the 9 months following surgery. There are no randomized trial. There are very few trials which are large in number or Randomized study demonstrated that cumulative probability of pregnancy in 216 infertile patients with severe disease 2 years after surgery was significantly increased. So we have talked that endometrium is not at fault, and severity of disease can also be reduced after surgery, and the results are same. All these factors prove that endometrium per se is not responsible for lower fertility. Then there is another question that we will be discussing subsequently, that endometriosis and ICSI, there is not much literature, and there is no much evidence to prove that ICSI over IVF improves only in cases where there is a poor ovarian reserve and you have very few follicles, that ICSI is recommended. Laparoscopy, sometimes we have done IVF, patients have come to us where IVF has been done and they have taken long treatment, but unfortunately, because we talk too much about non-invasive techniques and laparoscopy has not been done, but just simply doing the laparoscopy, draining her cyst, and she conceives spontaneously also. So laparoscopy may still be considered the treatment of endometriosis after multiple failed IVF cycles. And a recent study has reported that female with deep infiltrative endometriosis found that extensive laparoscopic excision of endometriotic lesion improved pregnancy incidence significantly. But till we have better data, we have to trust and we have to go with our own experience. So what about the embryo? As we've already talked about embryo, the transfer of embryo that have been selected as being chromosomally normal will lead to increase in success rate of IVF in endometriosis patients. Many investigators studying the effect of blastocyst development in implantation, and they mentioned that endometriosis is detrimental to implantation, and reports are conflicting, but some say that early embryo development in patients is at fault, and if we are transferring a clear beautiful blast with no chromosomal abnormalities, chances of getting a healthy pregnancy are significant. There is to date no compelling evidence that endometriotic patients benefit from significant standard agonist or antagonist protocols, with the notable exception of prolonged GnRH agonist downregulation procedure. So I just want to conclude that endometriosis is mostly underdiagnosed, and primary and secondary caregivers should make sure that if patient is otherwise normal and infertility is unexplained, either they should proceed with the laparoscopy at their center or they should refer the patient, because timely diagnosis, timely management saves your patient of lots of problem. And ultrasound and MRI also may not diagnose. It's either the symptoms of the patients or the diagnostic lapro, and mild and minimal cases can be very easily managed with the controlled overstimulation with IUI. Protocol can start with a simple Clofert Latrazole or gonadotropin depending on patient's age and her hormonal profile. And in moderate cases, we can give agonist for 3 to 6 months, or we can give OC pills also, and then we start our stimulation protocols. Severe cases, we have to do surgery. Again, there is a dictum, when you are treating endometriosis, treat endometriosis. When you are treating infertility, treat infertility. There again a debate whether we should wait after surgery, but my take on endometriosis is, as soon as we operate our patient, we immediately in the next cycle we take up the patient for IVF, and results are remarkably good. So once we have operated on this patient for endometriosis, we should not be waiting for any further treatment. Thank you. Thank you so much for your patience and your precious time. We look forward to meeting you in Nimrana very soon. Thank you so much. Dr. Sarpreet, I think Dr. Sarpreet has joined. Yes, he's joined. So thank you, everyone. So may I invite Dr. Sarpreet to start his presentation. Thank you so much, everybody. And we have the King of Embryology now. You have, sir, already been introduced. You were not there. We appreciate all your awards and your academic achievements. No doubt it will be a mind-blowing presentation from you. Over to you, Dr. Sarpreet, sir.
Yeah, thank you, ma'am.
Welcome, Dr. Sarpreet. Thank you so much for sparing your time for us.
Thank you so much, ma'am. First of all, I would like to thank the organizers, especially Dr. Seema Mittal, for inviting me. So I'm going to speak on clinical interpretation of semen analysis. Yeah, semen analysis is one of the most commonly ordered tests, but to my surprise, the interpretation of various variables is seldom understood by the practicing doctors. So I thought I should take up this topic and try to touch upon the minute details. Why is it important? Everybody knows that the male factor incidence is increasing with every passing year, and even the incidence of infertility is increasing, and the chunk of male contribution is almost 50% now. And there are many things which are coming up in the evaluation of male infertility which were previously ignored. People hardly used to get a semen analysis done in good old days, and when we used to go go for the cases, we used to find the patients with the oligospermic and at times azoospermic also. There was hardly any evaluation, but now people are becoming aware, and they are getting the male evaluated, and we are even looking at the molecular things. We're even looking at the DNA now in some patients, and we have begun to understand that male is not only a sperm provider, but male is important for a good and healthy sperm is important for the process of implantation of embryo also. And in fact, in the later stages of development of an embryo, male factor is predominant over the female factor, and it is responsible majorly for the implantation. In the early stages of embryonic development, male is responsible for the first mitotic division. So in case the male factor is compromised, sperm is not healthy, then you will find the embryo growth is quite slow. But in a good sperm, the embryos will grow at the normal pace, and they are more likely to implant. Azoospermia also has increased, and we find around 10 to 15% men presenting to our clinics to be azoospermic. So this also needs special evaluation. Unfortunately, in our setting, as I told you, the male factor is ignored. Proper history is not taken. At times the patients will come up with a history of mumps, a simple history, about childhood pain in the jaw and all that will give a lot of information. So, and they are not examined. So we need to develop a standardized approach to the male patient. This is one which we took from Sandro's Esteves paper, and he gave a flow chart. He said first you take a clinical history and then examine the patient, and at least 2 semen samples should be analyzed for semen analysis at least. And depending on the results, you should either go for a sperm function test or an endocrine evaluation, which is generally FSH and testosterone, and LH and prolactin can also be added. Additional testing comprises of genetic evaluation, TRUS or transrectal ultrasound, MRI or scrotal sonography, and there is a special retrograde ejaculation assessment, which we'll not be touching upon in this lecture, but yeah, there is a special protocol for that. At times, in azoospermic patients, you can go for a testicular FNAC or biopsy. So this is what he postulated in 2011. And many times patients who fail to conceive after 2 years of marriage or are concerned about their future fertility, they will come in for a semen analysis examination. A lot of young patients do come in before they're getting married nowadays, and patients who are suffering from any inguinal hernia or they also want an evaluation nowadays. Varicocele patients, onco patients, they also want an evaluation nowadays. So it is becoming a very important test because it gives a lot of information. So the relevance is clinically, it's a cornerstone of male fertility evaluation. It predicts time to pregnancy, and also it gives you a reasons for recurrent pregnancy loss. As I told you that a lot of implantation of embryos is dependent on the male factor. So it can give you a lead into why there is a recurrent pregnancy loss or why there is a failure to implant. It has a negative effect on IUI and ART outcome. It also transfers genetic defects via ART. So if there is a severe oligospermic patient, azoospermic patient, then you should make the patient aware, there is a high likelihood of a genetic anomaly also getting transferred. So you should always evaluate such patients genetically and then counsel them about the risk of transmission of genetic diseases so that the patient makes an informed choice And so you should be clear in your approach that I have given the information, now it's patient's choice. And it's shown to be associated with overall poor health, life expectancy, and lower quality of life. Some neurological diseases have also shown to be associated. So what is the clinical relevance? Let's look at the composition of seminal fluid. Testis is contributing around 2 to 5%. Only spermatozoa are coming from testis. Rest of the 2/3 of the secretions is coming from seminal vesicles, chiefly fructose, which provides energy, prostaglandins, and semenogelins. Semenogelins are the enzymes, are the components which hold the semen together. When the semen is ejaculated, it is ejaculated in a gel form. So semenogelins is which keep it in a gel form. And prostate is contributing around 1/3 of the seminal fluid, chiefly acid phosphatase and proteolytic enzymes. So semenogelins keeps the semen binded together, whereas proteolytic enzymes helps in the dissolution of that binding. It helps in liquefaction of the seminal fluid. So there is a balance between the two, and if there is an imbalance, you can have enhanced liquefaction, which can have its own share of problems, which we'll come to in later slides. Bulbourethral gland is contributing less than 1%, can be ignored. So what all do we analyze in a semen analysis? If you look at the gross macroscopic picture, it is appearance. WHO has asked us to evaluate the order, but I will not recommend you to evaluate the order. Liquefactions, viscosity, volume, and pH. Whereas if you look at the microscopic picture, it's agglutination, concentration, motility, morphology, vitality, and round cells. We'll touch upon each aspect along with its clinical relevance. So quantitative parameters, total number of spermatozoa, which is a reflection of testicular function. pH, as I explained you, it's a reflection of the patency of post-testicular duct system, because alkaline is coming from seminal vesicle and acidic is coming from prostate. So if there is a blockade, then either alkaline will dominate or acid will dominate. Volume is again depend on the secretory activity of the glands, 2/3 from the vesicles and 1/3 from the prostate. Qualitative assessment, it represents the functional competence. So you have a good sperm number, but whether it is competent or not, that has to be seen. So it should be vital, that is, the sperm should be alive. It should be motile with good morphology. Then only it can do the job. So this is a chart from WHO to 2010. Over a period of around 540 days, they observed few semen samples, and they found that semen to fluctuate from 300 million to almost azoospermia at one point of time. See, this is showing around 250 million, and then it comes to nil at one point of time. So we have not seen such drastic variations in any of our patients, but we have seen around 15 to 20% variation in patient, depending on the sample, the abstinence and collection techniques and all, level of stimulation. So everything influences the semen parameters. So you should be aware that variations are expected. So it is best to examine 2 to 3 samples and then obtain a baseline data in almost all the patients. So shorter the abstinence, there is an improvement in motility, morphology, and DNA integrity. Longer abstinence improves volume, count, but decreases motility. So what factors influence the results? Inappropriate abstinence, WHO says 2 to 7 days, but generally 2 to 3 days is good enough. Incomplete collection of the ejaculate. The initial part of the semen has been shown to have the richest concentration of motile spermatozoa. So if the patient fails to collect the initial sample, if he drops it's outside the container, then the sperm will have low motility. So you have to ask for the completeness of the sample from the patient, and you have to give him the instruction that he has to, ejaculate the whole sample into the container. If he's getting the sample from his house, then inadequate transport, inadequate temperature conditions, anything can influence the sperm parameters. Analytical variables can be a different protocol, a different SOP, procedural differences, or there are endogenous factors such as high fever and medications which affects spermatogenesis for a period of good 72 days, almost 2.5 to 3 months. So this is just an example that fever is affecting any history of febrile illness in the last 2 months can lead to even azoospermia. If the sperm concentration is affected first, then morphology and then motility. The history of fever should always be taken. So is it mandatory to repeat semen analysis? No, there is no need to repeat. If it is normal report on the first instance, there is no point in repeating it again. But if there is a azoospermia or oligozoospermia, you have to repeat the test within 2 to 4 weeks, at least 2 times. And if the second sample is normal, then you can stop again because there is no point in repeating and doing it again. So let's come to the macroscopic parameters. Appearance is generally homogeneous gray or pearlescent, and you have to look for the color. If it is reddish brown, there can be some bleeding, hemospermia. If it is yellow, the patient might be suffering from jaundice or taking any vitamins and drugs. So in young men, hematospermia can be due to inflammation or any infection of the urogenital glands, whereas in elderly men, it can reflect prostate cancer. So keep your eyes open and do advise the patient accordingly. Order I will not touch upon order. Liquefaction is generally, it takes place in 30 minutes, less than 30 minutes, and the sperm gains its ability to move as the semen liquefies. But if it is more than 60 minutes due to any infection of lack of prostatic protease, then you have to think of any infection. And how does it liquefy? See, when you aspirate it into a syringe, 2 ml rubberless syringe, it should fall drop by drop. So it has liquefied. If it makes a long strand, then it has not liquefied. And in those conditions, you think of a prostatitis or a vesiculitis, those conditions can be thought of. Viscosity is a homogeneous stickiness, and it is influenced by if there is a the color is grayish white in appearance. But if it is transparent ejaculate, then there is an extreme reduction in the number of spermatozoa. Or if it is opaque, the sperm is highly concentrated. So these things also have to be noted while you are, examining the sample. High viscosity can be due to accessory gland dysfunction, inadequate secretion of prostate and seminal vesicles. The absence of coagulum can be due to the obstruction of seminal vesicle duct or ejaculatory duct. Because I told you seminal vesicle is responsible for enzymes known as seminogellins, which form the coagulum. And if there is anything wrong with the seminal vesicles or the duct, so the coagulum will not be formed. It will be a very transparent and very thin kind of secretion. So that should ring a bell that, there is something wrong with the seminal vesicles. It can be a case of CBAVD also, congenital bilateral obstruction of vas deferens. And seminal vesicle atresia is a very common part of the whole spectrum. If you look at the volume is around 2 to 3 ml, and it expresses the secretory activity of the glands, but also their response to the autonomous nerve stimulation elicited by sexual arousal. So a patient who is masturbating into a container will have a lesser volume, whereas during a natural course of natural sexual intercourse, he might be aroused and he might be able to produce the right volume. So low volume patients should be evaluated with care. So low volume will fail to neutralize the vaginal acidity, whereas high volume will dilute sperms, and it is an indication of a dilution of the sperm by accessory gland hypersecretions. Low reference limit 1.4 ml. So low volume, if you're finding a low volume, you have to ask for the abstinence. If it's a very short abstinence, then the volume is expected to be low. If it's an incomplete collection, these are the physiological causes. But if you have to look at the pathological causes, it can be a case of retrograde ejaculation. The semen might be going into the bladder. In such cases, you might have a drop or two coming out of the antegrade root. Rest of the main chunk of the seminal fluid goes into the bladder because of bladder neck obstruction. Bladder neck obstruction doesn't take place, so because of alpha receptors not working properly, so the bladder neck doesn't lock, or it doesn't kind of block the secretions from going backwards. So that's the problem of retrograde ejaculation. Or it can be due to ED obstruction, ejaculatory duct obstruction, due to CBAVD or any other reason. then the sperm will not be, it can be complete or incomplete, and depending on whether it is complete or incomplete, you will find either there is no volume or it's very low volume. Severe androgen deficiency, as I told you that the glands are responsive to androgen secretions. So if there is a deficient androgen in the body, then the sperm volume will be less. The similar conditions, similar things happen in hypogonadism also, and the CBAVD, as I told you earlier also. If there is a glands or if the ducts are obstructed, obviously the sperm will not flow forward. Seminal pH, it's a balance between alkaline seminal vesicular and acidic prostatic secretion. 7.2 is the lower threshold. And usually, if you look at the physiological, if your patient is ejaculated and you don't evaluate for a very long time, then the pH will increase. That is why it is said that you evaluate the whole semen sample within half an hour. We are doing it qualitatively with a pH paper, but you can do it with a pH meter also. This is how it takes place. I mean, this is the vas difference. This is a seminal vesicular duct, and when they join it, the ejaculatory duct forms, and this is the prostate. The prostate is giving all the acidic secretions, and seminal vesicle is giving all the alkaline secretions. So if it is alkaline pH, then there is a delay in analysis, as I told you, and or poor sperm handling. If the secretions are, if the seminal pH is acidic, it can be due to CBAVD, that is congenital bilateral obstruction of vas difference. When vas difference is obstructed, or seminal vesicular atresia is also common. So the alkaline secretions will not come in, and it will be a acidic pH. SVA genesis, it's obvious, and bilateral ejaculatory duct block. So neither sperm nor fructose will come. So in those cases, you have to, it gives you an idea about, fructose analysis also gives you an idea about the site of obstruction. If fructose is not there in the seminal fluid, then the obstruction is distal to the formation of ejaculatory duct. So it is somewhere here. So it gives you an idea where the blockade is. Looking at the microscopic evaluation, we use Maker's chamber. So this is how the sperm looks like in a Maker's chamber. It's a 10 by 10 grid, and either you have to take the number of sperms in all the 100 squares, or you can take it in 30 squares and divide by 3. If the concentration is less, you can take it in all the 100 squares and divide by 10. Low reference limit 16 million per ml as per the new WHO criteria, and total sperm number is 39 million, which is the constant for the last 2 to 3 WHO criteria. Oligospermia can be due to incomplete sample collection. So the history of collection and abstinence is very important. Varying sperm, low abstinence also gives low sperm count. History of fever, history of exposure to drugs, or any other occupational disease. So these histories become very important. Cryptospermia can be due to secondary to testicular failure or obstruction inside the testes, epididymis, vas difference, or ejaculatory duct. Cryptospermia is a condition where, or azoospermia is a condition where you see sperm on one occasion, a few sperm on one occasion, and the next time when the patient comes in, there you don't find any sperm. Coming to the motility, it's very important for sperm to be, rapidly, progressively motile in order to, have the ability to reach the fallopian tubes and fertilize the oocyte. So generally, we grade it into 4 types: rapid, progressive, slow progressive, non-progressive, and immotile. As the name suggests, it's obvious. So you can't do it with eyes. You have to take the help of computer aided semen analysis to get the right grading of the motility. Low reference limit for motility, non-progressive plus progressive is 42%. For progressive, it is 30%. Motility decreases due to collection issues, high abstinence, exposure to temperature, time of assessment if it's more than 1 hour. So again, in all on samples, the analysis should be taking place within 30 to 45 minutes. Infection, anti-sperm antibodies, and there are some syndromes such as a Carter-Jenner syndrome, in which it's a ciliary dyskinesia and the sperms don't move in such cases. They are live, but they're immotile at the same time. Again, in some cases of pyospermia, anti-sperm antibodies, again, the motility can be compromised. Varicocele patients. If you look at the sperm vitality, it is the ability of this. It is, you have to see. I told you that there are immotile sperm can be live or they can be dead. So the live sperm will not take any stain, whereas the dead sperm will be stained pink in case you stain it with the eosin nigrosin stain. So in this case, if you look at both the sperm, the top sperm is a dead sperm which is stained red, whereas one which is white is a live sperm. So this test helps you in differentiating between an immotile dead and immotile live sperm. Because if you find that there are some immotile live sperm, you can still do take them on a real-time examination, and you can still do an ICSI with them. So that becomes very fruitful for the patient because they can have their own baby. And if you don't know about these things, then you might just advise the patient on seeing all the dead sperm, all immotile sperm. You might advise the patient for a donor sperm. But in such cases, definitely, patients can have their own babies. As I told you, live but immotile sperm, structural defects. So if a person, there are two people, if one is dead and the other person, the legs are broken. Something with legs are broken, it's a Cartagena syndrome. The patient is live, but he's unable to move because, he has got knee issues or hip issues or something. So such patient will be able to do the job. But in case it's an immotile, non-viable sperm, it can be due to any epididymal pathology, any immunological reaction, anti-sperm antibodies. The sperm is actually dead. So you can't use that sperm to produce a baby. Round cells, again, you have to many times you see a slide and you find these round cells. You see a lot of round cells are there in this sample. Everywhere there are round cells. You have to differentiate these round cells. If you find them more than 1 million, you have to differentiate them from leukocytes or immature germ cells. And we do it with the help of a peroxidase positive stain in which the leukocytes are stained purple, whereas the sperm will not be stained. It is also said that there is no relationship. There is a relationship between WBC's concentration and semen quality is questionable in men. Leukocytospermia is present in 61% of the semen samples if you take a random evaluation, but significant bacterial growth was detected in only 35% of the semen sample. In abacterial leukocytospermia, with a treatment with a COX inhibitor and decreases leukocytospermia and increases sperm concentration. So in such cases, even a COX inhibitor like a NSAID drug will also work well. In abacterial leukocytospermia, you can simply give him an aspirin or a crocin or a brufen, and it will be able to take care of the leukocytospermia and increase the sperm concentration. This is again a leukocytospermia, and the point which I want to make here is that it's an important cause of reduced counts, reduced motility, and poor shape and size of the sperm. That is oligoacinoteratospermia. Treatment is very effective. You have to give antioxidants as well as antibiotics. And as the previous slide says, you can also give them a trial of COX-2 inhibitors. So also you have to, if you give, then you will see a good improvement in the counts and motility in such patients. Many times you see these aggregates of sperm. They are either joined head to head, head to tail to tail. You find these aggregates and they impair the motility of a sperm, and it becomes difficult for the sperm to travel and fertilize the oocyte. This is generally due to the interruption of blood testis barriers such as testicular torsion, carcinoma, and orchitis. And it can be a reason that you're finding a normozoospermic sample, but the patient is unable to conceive. So it's a cause of unexplained couple infertility. So in case everything is normal and the patient is not able to conceive, then you should think of unexplained causes. And the number one unexplained cause is agglutination. Also, high DNA fragmentation is another cause. Another cause which can be, if normal counts, normal motility, but the morphology can be poor. So let's see what are the how a sperm looks like. There is a head, there is a tail, almost the length is similar, and there is a Then there is a tail, head, midpiece, and tail. Head and midpiece, their length is similar, but obviously they look different. Tail is almost 5 to 6 times the length of the head, going up to 10 times. And if you look, then the head is generally spherical, and you can see there is a differential staining at the top, that is the acrosome, and which is stained little light compared to the central area, that is the nucleus, which is stained dark. And it identifies patients who are at risk of poor fertilization or failed fertilization with standard IVF treatment. In these patients, we have to go for a technique known as FOGSI, in which we are able to select the best sperm and transfer it to the oocyte. So morphology can be defective in cases of impaired spermatogenesis, any epididymal infection, any testicular infection, and there is a condition known as excessive cytoplasm around the midpiece, and these excessive cytoplasmic bodies, they produce ROS and damage the DNA of the sperm. So you should have a special eye for these anomalies. Many times you find that the sperm heads are very large and they have multiple tails. Special attention should be paid to these sperms, because there's a genetic association and they don't improve generally. Then it becomes a case of donor sperm. Globozoospermia, globozoospermia in which acrosome is missing. I told you about the nucleus and the acrosome. If the acrosome is missing, the sperm becomes round, and these sperm are unable to fertilize because acrosome is required for fertilization. In these cases, you have to go for ICSI along with oocyte activation. There is a genetic association also with this condition. Tail anomalies, there can be various kinds of tail anomalies. I don't want to go into the details, but then ICSI is a good treatment for such patients. Sperm has got a centriole, which is responsible for first mitotic division, as I told you earlier also. And any defect in the centriole can lead to failure of embryonic development. So it is said that don't interpret the sperm number, motility, and morphology individually, but they have to be evaluated in a combination. So a poor sperm number can be compensated by high morphology and high motility, whereas a poor morphology can be compensated by a high sperm number. So evaluate all of the three together. So when you done a semen analysis and taken a proper history and physical examination, the first step of the evaluation is over. And then you come to know whether you have to go for any additional microbiological test or a transrectal ultrasound or a genetic examination. So these are some of the examples in which you should be able to make a diagnosis on seeing the semen sample. Like here, the pH is raised, viscosity is a little more than normal. You see agglutination, and so immediately when you see agglutination and high pH and high viscosity, you think of that there is some infection in the body. So this is the case of oligosteroteratozoospermia, and the cause is inflammation or infection of the urogenital tract. So accordingly you think, and accordingly you evaluate the patient. In this, the progressive motility is just 1% and non-progressive is 2%. So you will obviously think of extreme actinozoospermia, that is very low motility. And this can be due to Cartagena syndrome or any other ultrasexual defect of the sperm tail. In this, the sperm, but you see their vitality is 80%. That is, the sperm is live but immotile. So a simple semen picture will give you a lot of information. In this, the progressive motility is 0, non-progressive is 2%, but vitality is also 0. So what can you think of in such a patient? This is a case of necrozoospermia, and it can be due to any epididymal pathology or a spinal cord injury or polycystic kidney syndrome. This is all a part and parcel of these conditions. So in such patients, you take a second sample and you might find a flickering motility. Keep a gap of around 1 hour, and you might find some of the motile sperms. Your second samples are usually better, and if you have got a ICSI machine, obviously doing an IVF with a second sample might be difficult in such a case. But if you have got a ICSI machine, then you can have a natural conception also. I mean, conception through IVF ICSI also, because even if you get a flickering motility, you can still pick up the live sperm and differentiate it from a immotile dead sperm. Again, globospermia we have discussed in detail, and the message is that ICSI should be followed by artificial oocyte activation in such cases. So morphology also is important it has to be done in almost all the patients. In case you have few drops of ejaculate, a very low volume, again it's a case of either retrograde ejaculation. So you ask the patient to masturbate, you find that there are a few drops of ejaculate. Tell him to give you a sample of urine. The urine has to be collected in a pre-warmed 4 ml of semen collection media. So when he gives you urine, then you check for the presence of sperm in the urine. It might be just dead sperm, but it still gives you an idea that the retrograde ejaculation is taking place, and you prepare the patient in a different way when you're taking up the patient in the second evaluation. Okay, I'll not touch upon azoospermia, but the only basic thing I'd like to tell you is that in azoospermic patients, always centrifuge the sample and for 3000 G for 15 minutes, and then again examine the pellet and do it at least 3 times over a period of 2 months. And if it is consistently azoospermia, then give a report. Cryptozoospermia, again, it's at times sperm can be there, at times sperm cannot be there, or not there, and you see there is nothing. But when you centrifuge, you see a sperm in the pellet. So that is how you have to go for cryptozoospermia. So I'll not go into CBAVD. In the CBAVD, volume will be less, pH will be less, and there will be no sperm, nothing in the sperm. So you will immediately think of CBAVD. But pH is very important. In case the pH is normal, then you can't think of CBAVD. Only volume is less, rest things are normal. Think of severe hypoandrogenism. Then there is a androgen glands are hyposecreting, so that patient is not able to produce the right volume. So in the end, I would like to summarize the importance of doing a semen analysis. Besides what I've told you, it also helps you in finding out the right treatment protocol for the patient. Depending on the count and motility, you can either go for IUI, IVF, and ICSI. Generally, they say that if you have got more than 10 million, then you go for IUI. IVF generally between 1 to 10 million, or rather 5 to 10 million. ICSI if it is less than 1 million. But again, if there is a high degree of DNA damage, DNA we have not touched upon because of lack of time. If there is a high degree of DNA damage, you should go for a TISA ICSI, or at least a ICSI in such patients. Limitations of semen analysis, it's a test which looks very easy, so a lot of people do it in the wrong way. It is inexpensive. Yes, it is inexpensive, but it is generally done by poorly trained technicians, and generally we have seen that the results are not, it's not done in the proper way, and results are not as they should be reported, and even the proper reference values are not followed in most of the labs. It's a poor predictor of fertility, because fertility is a couple concept. It's generally seen that men with variables outside the reference range may be fertile because they've got fertile wives and other reasons, and men with everything within normal limits may still be infertile, because it's a couple concept. You can't put it on one, either the male or the female. The microscopic examination doesn't provide information on the functional integrity of the spermatozoa, and you have to go for a higher test, such as the DNA fragmentation test. For ultrasexual defect, you have to rule out the cardiogenital syndromes, and it doesn't comment on the ability of sperm to undergo acrosome reaction at the right time, or it doesn't comment on the zonobinding capacity of the sperm. So there are a lot of strengths and weaknesses associated with semen analysis, which we have discussed over a period of few last 20-30 minutes. So we'll not touch upon them. And with this, I end my presentation. Thank you so much, and I'm open to questions.
Very, very elaborate and thoughtful presentation. Thank you, sir. Thank you so much. It was really informative. Over to Dr. Mona. And one question I wanted to ask you about, you said if they are immotile but they're live sperms and we can go for ICSI. So won't there be any genetic defects if the sperm is immotile and still live and we're doing ICSI?
So there can be genetic defects. In the initial part of my presentation, I told you about, you have to run the genetic test. Most of us don't do it, and you have to counsel the patient that these are the pros and cons. This is what we are going to transmit to the progeny, and if the patient consents after after being counseled for the risk of genetic transmission, if he consents to doing an ICSI baby, then he should be allowed to go for ICSI baby. If he says, okay, I don't want to take the risk, go for a donor sperm, that you have to make him aware, and then he makes an informed choice. The
So
couple.
do you recommend that we should do PGD for such embryos once the ICSI has been done for such a patient? The embryos are to be tested genetically, or I mean, what is your experience? You are such an
in
experienced
in
physiologist.
in case the patient is having microdeletions of Y chromosome microdeletions, then that will be passed on to the male baby, but the female baby will be spared.
Okay.
So, but genetic, yeah, you can go for a PGT analysis. On PGT analysis, at least, they will not divulge the sex of the baby, but it will be an indirect disclosure that, it's a female, it's a normal baby. So you might have some idea that it's going to be a female baby.
Right, sir. So it was more than complete. Mona, you have something to say, Dr. Mona? Yes.
That was a very informative talk, and you have touched all the aspects of male infertility. What I wanted to know is, if the DFI is more, should we go for testicular sperms instead of ejaculated sperms?
So, ma'am, DFI, testicular sperm over ejaculate, because you are talking about the cases in which we are having ejaculate, but the DFI is more.
Yeah.
So it's definitely an indication. There are only three indications of going for a testicular sperm. Cryptozoospermia, yes, it's an indication. High DFI is an indication. Oligozoospermia, along with high DFI, is an indication. Oligozoospermia in itself is not an indication of going for a testicular sperm. So these are the three established indications, and you can go for in case it's a very high DFI. But you have to again balance it out clinically. If there are just a couple of eggs in the patient, 2 to 3 eggs, 4 eggs, then you might refrain from doing a testicular aspiration or a testicular biopsy. In those cases, you should go for a ejaculate only.
Okay.
Because the
Saraprit, I
benefit
would
should
like to
be
differ
in
here.
terms of cost.
Dr. Saraprit, can I just, in our practice, what we are doing, instead of taking the voice is resonating.
Two devices are there or what, Dr. Sonu?
No.
Okay.
But if the patient is ejaculating every day, that is more beneficial rather than doing a testicular aspiration in patients with a high DFI.
Yeah, there is.
Right.
See, all IVF patients, we ask them to ejaculate on a daily basis, because normally as soon as the stimulation starts, the patient stops ejaculating, which is not the case, which should not be done. So we advise all male patients to ejaculate daily, and patients with established high DFI values, we ask them we counsel them beforehand that we will take a second sample also. So if the pickup is around 10 o'clock, we ask them to give us a sample around 10 o'clock, and the second sample around, say, around 11:30 or something like that, so that timelines are also not disturbed. And we preferably use the second sample, and we've generally seen that second sample is better in terms of motility also. So in case you find a patient with, low motility, request them for a second sample. You will find that some motility advantage will be there along with low DFI. So the DFI is less by almost 5 to 10%. But if the patient is having a DFI of 50%, 45%, even more than that, then a second sample is not going to help much. So in those cases, a testicular biopsy will help, provided you have enough number of oocytes to justify the procedure.
Yeah, definitely. We always try second sample, but if still that is not good, then yes, definitely we have to go for testicular aspiration.
Yeah.
Thank you so much. Thank you, Dr. Saraprit Singh. That was very nice, very informative talk.
Thank you, ma'am. Thank you.
Dr. Seema, with your permission, I'll just like to showcase this newly launched product of ours, which is a rational combination for male infertility. We have LycoRed-M tablets now, which are a combination of N-acetylcysteine, L-carnitine, CoQ10, lycopene, zinc, and selenium. And with added advantage to win the race, L-carnitine is sourced from Switzerland and lycopene is sourced from Israel. So thank you so very much for such an informative session going on today. Thank you, Dr. Seema Mittal, ma'am, and the faculty.
So can I have my most worthy panelist and the CV slide displayed on the screen, Deepika ji? We have Dr. Sonu Balara with us, who is the secretary of our Indian Fertility Society Haryana chapter. And Dr. Dipankar sir has also joined. And we have Dr. Neeru Thakral, who is our past president. Just display the CV so that our audience know our panelists. So we have Dr. Dipankar Banerjee with special interest in reproductive endocrinology and more than 3 decades experience and working in interventional sonography, and he's running courses for practicing doctors in fetal medicine and more. I think those who are attending our webinars regularly know what an authority he is. For us, our verdict in his court is always final. And next we have charming Dr. Neeru Thakral, who is the director of Morpheus Thakral IVF Center. And she is, I would say that I have yet to find another workaholic person like her. She's very, very hardworking. She was past secretary IVS Haryana chapter, clinic secretary IAG, and she has presented many papers. She's been organizing chairperson for operative hysteroscopy TLH workshop in Fertivision, and organizing chairperson for first annual conference Haryana chapter. It's a pleasure having you here, Dr. Neeru. Welcome.
Thank you, Dr. Seema. Thanks a lot.
And we have our most glamorous and beautiful Dr. Sonu Balhara, who is presently Director ART Fertility Clinic Gurugram, Secretary Haryana Chapter of Indian Fertility, and she has contributed to many research papers and papers in a textbook, authored book on DNB Part 2, and associated with various charitable programs in various NGOs in NCR. And she is definitely going to share her knowledge with us. Welcome, Dr. Sonu. So we have Dr. Sarita Chaudhary, who is medical director of Adam and Eve Test Tube Baby Center, Noida, and who has delivered more than 5,000 ICSI babies in the last 15 years, and actively involved in social activities. Welcome, Sarita. I hope she's there. Then we have with us, Akriti is not there. Yes, next. Then we have Dr. Anshu, Deepika ji, Dr. Anshu Yadav, Director GG Vishra Infertility Hospital, young brilliant mind with us, and today we will be discussing certain questions. We will give 2 questions to each of our panelists. Can you have a slide displayed or displayed in the end? We have we will be putting 2 questions to each of our panelists, and Dipankar sir would be the final authority. So let's have the first question. And Dr. Alka's smiling face is there. It's so encouraging, and you know, I keep on drawing energy from there. Thank you so much. So first question.
Good evening to all.
Yes, sir.
Good evening to all.
गुड इवनिंग सर. गुड इवनिंग सर. आपको देख के भी लगता है कि फॉल्स अपने आ रही ना, आपके जबलपुर वाले फॉल्स की याद आ जाती है.
अरे वाह.
कैंपटी फॉल और कौन सा है वहाँ? कैंपटी तो नहीं है सर, कौन सा फॉल? यस. सो फर्स्ट क्वेश्चन टू वी स्टार्ट विद डॉक्टर सोनू. यस, फर्स्ट क्वेश्चन. What percentage of endometriosis cases do you attend in your clinic, Dr. Sonu?
Okay. So nowadays the endometriotic patients are on the rise because people are planning for a family later on in life. So we see quite a lot of patients, like you can say around 30 to 40% of the patients, the females who are coming, they have endometriosis, and we are doing IVF because of the endometriosis in those patients.
Endometriosis is becoming common, but the thing is that endometriosis diagnosis is very important when we encounter with the patient with infertility, infertile couple. And the incidence might be more what we are looking at present, but definitely looking at the scenario, the delay, what Dr. Saab has told, that this main reason is that the delay in the childbearing definitely increases endometriosis, and definitely it is, I think 1 or 2 cases in 3-4 days, definitely I come across with the endometriosis cases.
Dr. Neeru, you want to add anything?
Yeah. Around 20% of the infertile patients are endometriosis, and in fact, we should catch them young because mainly we have the school girls, they are absent from the school. So we should have the suspicious in mind and start the treatment at the right that is. Otherwise, they will come to you later on when they have lost all the ovarian functions, and then they have to go for IVF. So we should definitely catch them when they are young.
Right. So next question is for Dr. Niru. As you have mentioned that we should diagnose early. Okay, young girls are symptomatic and we can think of endometriosis. And as Dr. Sonu has rightly said that incidence is increasing now. And we all have witnessed, like if we think of 2 decades back and now. So how do you diagnose endometriosis in your patients before taking them up for any treatment?
First of all, history. History is very important when they have history of dysmenorrhea, dyspareunia, PV examination, which we all have lost the art, and tenderness, rectal tenderness, bilateral fornix tenderness, then ultrasound, we can see the kissing ovary, POD tenderness, ovaries are enlarged, we can see endometrioma. All these things, they are diagnostic. CA125 is not the very diagnostic because that is raised in many conditions, PID or anything also. Earlier, definitely diagnostic laparoscopy was thing to be the gold standard, but now in the era of assisted reproduction, it's not the gold standard. And especially in IVF cases, we don't go for laparoscopy before IVF because we are in fact harming the patients. If we are going for diagnostic laparoscopy, we are harming in the way of we are reducing the ovarian reserve. But yes, in two conditions, we have to go for laparoscopy when we think during our examination that yes, these follicles will not be accessible during aspiration. In those cases only we go for laparoscopy. Otherwise, we don't go laparoscopy for any endometrioma. And secondly, pain. When the patient is having pain, in those cases, we go for laparoscopy. Otherwise, we directly go for IVF, especially in stage 3 and stage 4. But yes, in stage 1 and stage 2, if patient doesn't want to go for assisted reproduction, those cases patient want to try normally, young patient, there definitely we have role of laparoscopy. We do laparoscopy, remove the adhesions, and patient can try easily 1 or 2 years. But stage 3 and 4, there is no role because repeated, if we are doing laparoscopy, we are definitely harming the patient. We are decreasing the ovarian reserve. So there is no definite role nowadays.
Dipankar sir, what is your take on this question? How do you diagnose that this is endometriosis? Because for me, it's only laparoscopy that I can give a clear picture. And at times, yes, histopathology may not be there because sometimes we burn the tissue so much that histopathology may not be telling me that this is endometriosis. But laparoscopy definitely does help me in my practice. Sir, what is your take on this? Do you save it after? Sir, unmute. Do you save it for after pickup and after failure, or do you do like for us? It is a first line diagnostic tool.
See, laparoscopy in diagnostic or diagnosing the endometriosis might be a very good tool, definitely a gold standard. But laparoscopy comes late when we do a transvaginal sonography. What I do in my clinical practice, whenever we do a transvaginal sonography, there are signs of many things which are. Is it audible? Hello.
Yes, sir, you're audible, sir. Yes.
There are many things which we can identify during doing in transvaginal sonography, and most importantly is the spatial orientation between the ovary and the uterus. Whenever we do a transvaginal sonography, if the transvaginal sonography probe doesn't reach to the ovary and in between there are some tissues we are not able to go till ovary, definitely there are adhesions, and we have to find out the reason behind this and differential diagnosis between pelvic inflammatory disease and endometriosis. If along with the infertility, definitely it depends upon the patient's economic and social status, whether it is PID or whether it is endometriosis. we have to have a very high index of suspicion while doing transvaginal sonography. Even simple amount of blood collection in corpus luteum, which looks like chocolate cyst with adhesions, definitely the suspicion goes towards endometriosis. If patient wants a laparoscopy for diagnosis, definitely we can go for laparoscopy. And what doctor has said that please don't destroy ovary while doing laparoscopy and treatment of endometriosis, because it will reduce AMH. So it is better to have a great amount of suspicion while doing transvaginal sonography with color Doppler, with spatial orientation, with ovaries and uterus and other pelvic structure. It gives a most of the time, a clear idea about endometriosis.
So, Dr. Sunil, you have to say anything about it? What is your take?
Dr. Seema,
Go on, no problem.
if the question simply is diagnostic laparoscopy before IVF in suspected endometriosis, then I would not do it. We would go in for IVF rather than doing a diagnostic laparoscopy before to diagnose endometriosis.
Ma'am, could you please join in
Change.
again?
Okay.
Dr. Sonu.
And so next question is to Dr. Mona or Dr. Sarita. Any of them is there? So what is the stimulation protocol for endometriosis that we would like to know from all of our panelists actually? So Mona? Okay, Dr. Anshu, please answer this question for us. What is recommended and what should be done ideally?
Yes, ma'am. Actually, we cannot recommend a specific ART protocol in endometriosis. As per the evidence, both GnRH agonist and antagonist can be used depending on the patient and the physician preference. So we can use any of the protocol because the results, considering the clinical pregnancy, live birth rates, are almost equal in both the protocols. So that all totally depends on what you prefer and what your patient prefer. Because in GnRH agonist, it is a long protocol, so the patient need to take injection for a long time. And in antagonist, it is a short protocol. So now most of the centers are moving towards the short protocol only. So that is basically depends on their and your preference.
Very right. So
What
that's
I think in endometriosis, I think we should preferably can go for long protocol because it helps to suppress the endometriosis. And then if we'll start stimulation after that, then the results may be a bit better. For endometriosis only, I think long protocol is preferable.
Very right. Actually, I go with the agonist protocols because that really helps. And just like most of the centers have now shifted to antagonist protocols, and fewer studies are there with antag, but I think that's also equally good, especially in cases where the ovarian reserve is poor. Dipankar sir, we would like to have final say from you. Sir is there or sir also logged out?
Hello.
I would
Yes,
like.
sir. Yes, sir. Sir, please tell.
For me, what I do with the endometriosis is depends upon the stage of the endometriosis. Should we go for fresh transfer or frozen transfer? That is very important. Second thing, nowadays I don't use long protocol. It is all short protocol.
Right, sir.
If there is very low AMH and patient wants to use their own eggs, then I use 3 or 4 days of GnRH antagonist in the beginning, followed by antagonist protocol. Then give a GnRH trigger and don't do the embryo transfer, freeze them. If endometriosis is severe and we can get few embryos and make blastocyst, then what I do, I give them GnRH analog depot for at least 2 to 3 months to make them amenorrheic, followed by HRT and frozen embryo transfer. This is the most common protocol what I am using nowadays.
Sir, missed the last line. Just repeat again, sir.
Huh?
What are you giving? The last line, I missed it, sir.
No, in the last line, what I give that if patient is having endometriosis, came for IVF to you, two types of patient. One is very low, poor AMH and adequate AMH.
Right.
Whatever may be the case, if it is a very poor AMH, then I nowadays use GnRH antagonist in the beginning.
Very right.
And then freeze the embryo and give GnRH agonist depot, GnRH analog depot, 2 to 3 months, make them amenorrheic, hypogonadotropic hypogonadism. Then I give HRT and then do the embryo transfer. This is the most common, most of the time I am doing nowadays.
Sir, are you doing blast for all with low AMH also?
Absolutely, yes. Even there is no blast, I cancel the transfer.
Right. So Dr. Sonu wanted to say something. Dr. Sonu?
I just wanted to add, Seema, that there are studies that agonist and antagonist, both protocols have the same role, even for low AMH patients. And we are doing all antagonist. I'm not doing any agonist.
Right.
Because the recruitment is also, if we are giving a high dose for low ovarian reserve patients, the recruitment is the same, and we get a good number of blasts for the patients. Even 1 or 2. Usually, I am also doing all frozen embryo transfer with the blastocyst and no fresh embryo transfer in these patients.
Right. I think Anshu really answered well that it has to be individualized and every center and everybody it does according to patients. So next question to Dr. Mona Agarwal. Mona, are you using any drug treatment before endometriosis before IVF? This doesn't mean the hormonal supportive treatment for frozen embryo. Just like any other drugs, so many drugs are there in the market for endometriosis. Are you using any of them for reducing endometriosis? Unmute yourself, Mona. Yeah.
Seema, excuse me. I want to leave because some emergency. So please allow me to leave.
Sir, 5 minutes. Give us 5 more minutes, please, sir. Discussion becomes.
Let sir answer this. Let sir answer this.
Sir, you answer this question. Yes, sir. Any drugs, like so many drugs in market, EndoReg and all drugs, are we using them before IVF or just they're symptomatic?
Drug treatment for endometriosis before IVF.
Before infertility treatment, I would put it other way.
No treatment. It is start with the day 2 and go with the very high aggressive protocol to get more eggs.
Right. I think everybody will agree with the answer. Okay. Now, this question I can put to Dr. Sonu and then Dr. Anshu will answer. Aspirating endometrioma at the time of pickup, how many times have you done, Dr. Sonu?
Never in my practice till now. There is no role of aspirating an endometrioma either during pickup or at any other time because of the risk of infection in these patients. So there is no role of aspirating the endometrioma.
Sir, one point, one input. Accidentally, sometimes we do actually, and there is no infection actually.
This is the common practice should be, but inadvertently
it goes. Yes. That's what you are always, you tell the truth always, sir, because we have done, I think 2 or 3 times at least during aspiration, and nothing has happened, no abscess, no infection. It should not be done theoretically, but some studies say there is no harm in doing it. So I thought you're the best person to tell, sir.
Yeah, should we change the open pickup needle after if accidentally we have done it?
Yeah, we just flush it afterwards. Sir, anything? Okay, Dr. Neeru is there? जावा सर
ओके मैं निकल रहा हूँ थोड़ा काम है मुझको
सर एक लास्ट क्वेश्चन बस endometriosis ICSI is indicated in all cases or some cases of endometriosis. What are the indications, sir? Me, if they're good eggs there, I mean, we don't need to do unless it's a poor ovarian reserve.
ICSI is all for all, no conventional IVF nowadays in my center. My embryologist is my wife and she doesn't want to do conventional IVF because there are a lot of problems seeing next day the fertilization check and pronucleus and all. And if there is no fertilization in a poor egg reserve, then it is a flop show, then things becomes very difficult for the doctor. So our personal, since quite a long, most of the time, 99% we are doing ICSI. Even though we get single leg, we do ICSI.
Dr. Neeru?
In endometriosis, per se, there is no indication for ICSI. We can go for IVF. But yes, if we have added factor like poor ovarian reserve, elderly, low sperm count, poor sperm, the previous history of fertilization failure, then we can go for ICSI. Otherwise, there is, as per se, endometriosis is not the indication for ICSI.
So, sir just changes our direction.
Seema, in our center, in our clinics, we are coming back to doing IVF. So if the semen preparation that is normal, the count and motility, half eggs they take up for ICSI and half for IVF. And even if it is low ovarian reserve, if it is 1 or 2 oocytes, if even 2 mature oocytes, maybe they will do more of IVF rather than doing ICSI in most of the patients. But as it is for endometriosis, per se, there is no indication that ICSI should be done in these patients.
Right. Very good inputs we are getting. Dr. Anshu, tell me, when a patient has come with low sperm count, when do you take your patient for IUI and when do you recommend your patient to go for IVF?
Yes, ma'am. If the total motile count is less than 1 million, then definitely it is for ICSI. But if it is 1 to 10 million, then IVF can be done. And if it is more than 5, if it is between 5 to 10 million, then definitely IUI is a good viable option. So it basically depends on the total motile count, total progressive motile count. If it is good, then we can go for IUI as a good option. But for IV, ICSI, if it is less than 1 million, then definitely we should not go for IUI and we should directly tell the patient about ICSI, and her chances with IUI are very low in that case. So this is the total motile count, ma'am, actually.
Okay, this is good. Doctor Sonu, are you using any adjuvants in male infertility?
Not exactly. Actually, what our people they discuss that as it is, male infertility is very low. So if you're doing within 6 months, you're doing semen analysis regularly for any male, you may have a lot of variables as per the semen parameters. So I don't think there is any role from our side, but having a good diet and stop smoking, any addictions or any other factors which may lead to decrease in the semen parameters, that is good enough. So, and with the diet also, you can have a lot of antioxidants. So these are the things which we follow.
Dr.
Rather than
Neeru?
giving any adjuvants.
See, we have so many pharma companies if they attend our this. Okay,
Yeah,
so tell me.
They would never come to me, I think.
Yes, Dr. Neeru, tell me.
Yeah, rightly said by Dr. Sonu that diet is the first most part. But yes, I would definitely like to give adjuvant when my semen sample is morphological not good, when we have high DNA fragmentation, or when the patient is obese, diabetic. In those cases, I would definitely like to have good morphological sperms. In those cases, I definitely add the.
Actually, literature does say that using antioxidants help. Dr. Mona, you want to add?
Yeah, I think we should control diabetes and stop less of smoking, reduce the smoking, alcohol.
Drink,
They are
yeah,
all very
alcohol.
important. Low temperature. The male should not be exposed to high temperature. They are all things have affect the sperm. So I think this is also very important. After that, we just give antioxidants to all
Adding
our.
antioxidant does help. Should you agree with us?
Yes, ma'am, definitely.
Okay. So last question is to Dr. Mona first. Hormonal treatment for male infertility, low count, Mona. What are you giving and what should be done?
We just do FSH and testosterone levels just to see the hypogonadism in those males, and then we treat accordingly. Not much into it.
So, Dr. Sonu, Dr. Neeru, please share your experience. Because this treatment is very, very long and it is very, very, costly. So, patients normally don't afford. They want to go for a shortcut. So, are any of our panelists using hormonal treatment for hypogonadism or
Yeah, yeah. In these patients, we can give when the FSH is low or when the testosterone is low. Testosterone is normally around 300 to 500. If it's less than 300 or less than 250, we would definitely like to give either low dose clomiphene or an estradiol 1 milligram or letrozole. But definitely these have to give for 6 to 9 months, especially an estradiol we can give in obese patients where ratio of testosterone and estrogen is disturbed. When obese patient estrogen is high, so the ratio is disturbed. In those patients we can give. And hormonal definitely have role in hypogonadotypic hypogonadism. In those patients, we start with the HCG. We start with 2000 HCG twice a week for 2 to 3 months, and then we check the volume. If the volume is increasing, that means patient is little bit responding or increase in the testosterone level. Then we continue for 3 to 6 months more, and we can see the improvement. But yes, we have to counsel the patient that it may take 6 to 9 months to have
See,
the protection.
according to literature, like we don't give because you can give HMG, you can give HCG, but you have to give for almost 1.5 years. Dr.
Yes.
Sonu, please share your experience.
Seema, I don't have much experience in this, but what Dr. Neeru has said very rightly,
HCGs.
that this is to be continued for 6 months, 1 year. But definitely it has a role, and we
Yes.
see patients, they form sperms if they are coming. So it's not that this is difficult, and patients do take it and they respond also nicely to
But
these.
1 year, yes. 1 year is what they respond, not like 3 months, they have not responded, but 1 year, yes, definitely.
Yeah, but if there is little improvement in the volume or improvement in the testosterone, then only we give for more than 6
For
months.
continue.
Otherwise,
Otherwise,
after 3 months, we can outrightly say that there is no benefit. And patients sometimes say, okay, I'll take 1 year, then I can conceive naturally. No, very less
always.
likely. It
Right.
count and motility will have hardly few sperm. So that we can use for ICSI, IVF, and very rarely for the IUI. It's not that it will become 40 million after so much
So
time.
actually, we should preserve the sperms if, like on treatment, if they after 3 months or 6 months,
We get
we
something,
can
yes.
see some sperms coming. So we should
Sperms come
actually
after
preserve
6
them.
months, but yes, volume increase little bit and testosterone volume increase little bit. Sperm come definitely after 6 months only, 6 to 9 months.
So I think we conclude our discussion. May I invite our dear President, Dr. Alka, to thank all our panelists. It was really good sharing knowledge, sharing platform, and looking at the smiling faces.
Seema, I would like to just add that we have stopped doing, like we are rarely doing DNA fragmentation, because that also, if there is the fragmentation is high, then also there is no role of actually drug treatment. So if everyday ejaculation, and for we IVF we take 2 samples on the same day, that has a lot of benefit. So
Definitely.
actually, we have stopped doing DNA fragmentation also.
Thank you, Dr. Sonu. It was very important input. So over to Dr. Alka. And before that, I would really thank Deepika ji and everybody who has attended. Over to you, Dr. Alka. Yes, Dr. Alka is she's the senior most gynecologist at Narnol and special interest in high risk obstetrics, but she is academically always interested and motivating for all our endeavors. She's president of our Rewari Obs Gyn Society, member FOGSI Public Awareness Committee, member of District Medical Legal Committee. In fact, everything in Narnol, she is she is supervising and she is heading all the units in Narnol, and she's vice president. I am in Narnol, chairperson WDW Narnol, and this webinar and all our activities are because Dr. Alka is there. Over to you, Dr. Alka.
There is one question also in the chat, Seema. You can take that question also.
Okay, what is the question? Can't hear.
Chat. In the
I
chat.
saw that question. That was when Dr. Sarpreet was talking. And chat me, what is the question? Wait. Okay, one doctor said before transfer he gives 3 months of depot to make her period stop. So should we give a withdrawal after the depot and start the ET preparation? Very good question. So once there is amenorrhea, we normally start after withdrawal only. We don't start just with the amenorrhea. What do you say, Dr. Sonu and Dr. Neeru?
We can start even without a withdrawal, and actually we do a histro wash just to reduce the inflammation. So just putting some fluid with hysteroscope and then switching it off so that it comes out, doing that 3-4 times. and then we can start the HRT. We don't have to give a withdrawal for these patients.
Hey, you are doing hysteroscopy for all the patients after 3 months? What you said?
Hystro wash, we say that just to reduce the inflammation. It's not hysteroscopy. So usually we do it, but we can start it without any preparation also.
Theoretically, it sounds good, but you know, back of my mind, I always feel my patient can get pregnant anytime and she may not be following my course also. So,
of course, Dr. Seema, you have to do an ultrasound before that.
So I always make sure that she gets a withdrawal and then only we do the transfer. This is policy in my clinic and I will go with that. What about you, Dr. Niru? Dr.
Yeah,
Sonu also gave-
we can start after 3 months without cycle also. But
Right.
yes, I give them progesterone or OC pill for the advec therapy, because after the long 3 months or 4-month deport, they have bone marrow depression and they start having osteopenia and all. So I have dual advantage that it's advec therapy and patient is also psychologically think, yes, I got the period, and then we can start.
Menopausal patients, yes, we do start at times, you know, they don't get periods only and they get, I mean, they are prepared and then they start getting lining also. In those patients, we do without a withdrawal also. But young patient endometriotic, I feel, what do you say, Anshu?
No, Seema, the question is that after 3 months of this depot preparation, is a withdrawal necessary? So the answer is that it is not
It
necessary.
is not necessary. Yes, it is not
Yes.
necessary. But what we do practically, I always make sure that there is a withdrawal. And somebody has said that inflammation, like Dr. Sonu said, in hysteroscopic wash to reduce inflammation. They're saying by a drug can we not reduce inflammation? There may not be any inflammation. Also, it's just a practice to rule out all other factors, right, Dr. Sonu? That's what you want to say.
Yeah,
that
exactly.
normal endometrium. So it's not for only inflammation, but to rule out other anomalies or any pathology inside if it is there, or like you said, ultrasound can also be done. So there is some more question. Can we have a look at that?
No.
Inflammation can be reduced. It's done.
Yeah,
Okay,
definitely.
so it was really good discussion. I think we should sit more often. Over to you, Dr. Alka.
Good evening, everybody. It was very nice to be hearing all this. And I'll really like to thank you all the panelists, especially Dr. Sonu, Dr. Dipankar, and Dr. Neeru. It was nice to see you again also on this
definitely.
webinar
Love.
platform.
Thank
In
you.
my thank you note, I'll really like to thank all the delegates who have logged in,
Yeah.
because without them, if we keep on talking, it is of no use. And then least of all, Jagsonpal Pharma, they have been providing a platform constantly. And Dr. Deepika, she's been very sweet, all the way smiling, although she's tired, but she won't show it.
Dr. Deepika also has to come to Nimrana now. Dr. Deepika, you can't say no. See,
Yeah,
I think
everybody has to come
silver
to
jubilee of our
Nimrana.
webinars, golden jubilee of our webinars. You know, we have to celebrate there.
Hi,
Thank
Deepika.
you, thank
Thank
you,
you,
Dr.
Dr.
Bela.
Deepika. Thank you, Seema.
Thank you.
I take this opportunity and just present before you 2 or 3 products of ours. Divagest tablets of 2 mg as EndoReg for endometriosis. For male infertility, we have recently launched LycoRed-M tablets, which are containing the rational combination of N-acetylcysteine, L-carnitine, CoQ10, and then lycopene, zinc, and selenium. With the added advantage to win the race, we have L-carnitine from Switzerland and lycopene we are sourcing from Israel. Next is our Divagest. That is our natural micronized progesterone range of Divagest, sustained release tablets 200, 300, and vaginal soft gels of 200 mg. Also Divagest injection progesterone. So Jagsonpal is truly a progestin people. We have the natural micronized progesterone range. We have dihydrogesterone as Divatron. We have Maintain, hydroxyprogesterone caproate injections, and then L-irestanol tablets of Maintain, norethistron as CycloReg CR10 and plain 5 mg, and of course EndoReg 2 mg for endometriosis. So thank you all so very much, and we hope to see you again next month.